Welcome to Cardiology section number 9. Follow with us as we review arterial disorders.
So we're talking about arterial embolism or a thrombus. So they get an acute ischemic presentation. They get the 6 Ps. Pain, pallor, pulseless, paresthesia, paralysis, and poikilothermia. Paresthesia usually one of the later stages. So 80% of arterial emboli originate in the heart. Common cardiac causes are the rhythm caused atrial fibrillation, which forms a clot in the left atrial appendage. And mitral stenosis is the valve abnormality that's commonly associated with arterial embolism. It's 20 times higher risk than any other valvular abnormality. So if they say what valvular abnormality is likely associated with a patient who just had an acute arterial embolism to their left arm, you're going to answer mitral stenosis. If they ask you what rhythm is commonly associated with arterial embolism, you're going to say atrial fibrillation. There are some other causes. Septic emboli from endocarditis, hypercoagulable states can all lead to these arterial emboli, but these are the most common causes. Lower extremities are more common than the upper extremities, and they can occur in the mesenteric artery. So somebody with atrial fibrillation, the clot breaks off and then travels down to the superior mesenteric artery and gives them mesenteric ischemia. The initial treatment for arterial embolism is going to be IV heparin. Yes, in the hospital, when somebody comes with acute arterial embolism, you're going to call the vascular surgeon and start heparin at the same time. But on the test, you can only do one, and so you're going to choose heparin first, and then you're going to call the doctor. We'll use thrombolytics, or they can do angiography with a thrombectomy, or an open thrombectomy once you get the vascular surgeon there. So the answer on the test is, what will I do first? I will give the heparin and then call the doctor. Because if I'm calling the doctor and it takes time and the guy keeps shooting more clots to his arm, it's going to make things worse. We don't want to increase the burden. So treat and then call. Heparin, then call the doctor. Yes, in real practice, you'll do both at the same time. On the test, you can only pick one. Giant cell arteritis. Giant cell arteritis is important. It's called temporal arteritis if you're older like me. It's a chronic inflammation of the medium to large cranial blood vessels. It's commonly associated with polymyalgia rheumatica. These are the people that are like 50, 60 years old who wake up in the morning with that shoulder and hip stiffness. The way they often describe this is they're having scalp tenderness. So they brush their hair and it hurts, or they scratch their head and they get pain in the scalp. That's when you want to think about temporal arteritis. So they often get severe temporal or occipital headaches. They get the amaurosis fugax, which is that unilateral decrease in unilateral vision. They get claudication in their jaw, so when they're chewing and eating food, they start getting the pain in the jaw. Think giant cell arteritis. And this was the hair brushing. They'll have an elevated ESR. Temporal artery biopsy is diagnostic for giant cell arteritis. It leads to blindness if not treated, so as soon as you know they have this, high-dose prednisone is started to avoid the blindness. Peripheral artery disease is an obstruction or narrowing of the vessels causing disruption of the blood flow. This is where you get claudication in the calves. So this is the patient who walks like 1 block and then he gets his pain in his calves. He has to sit down and rest before it goes away. People who have peripheral artery disease, they have hair loss, atrophic skin, and they have dependent rubor. When they do get the ulcers, they don't heal very well, and they're very, very painful. So people who have peripheral artery disease, their ulcers are very, very painful. The initial test of choice for a patient with peripheral artery disease is the ankle brachial index of less than 0.8. Once you have done the ABI, then you can screen with ultrasound, do angiography. Angiography is the gold standard. So in the office, or the best test to do to screen for peripheral artery disease is the ankle brachial index. Then once you know that it's positive, you do these tests. Treatment for peripheral artery disease to control the lipids, antiplatelet agents like your silostazol or pentoxifylline are used. They're FDA approved. And then you can also do stenting and bypass if it's needed. Note that beta blockers are contraindicated in isolated peripheral artery disease. It actually makes the condition worse if it's just peripheral artery disease. So if they have coronary artery disease with peripheral artery disease, you will find them on beta blockers. But isolated peripheral artery disease, beta blockers are contraindicated. They will ask this question because it actually worsens the claudication. So remember this question right here, guys. This is them doing the ABI.